You are tuned into the Dr. Tina Show with Dr. Tina Moore. For more, visit drtina.com. On this episode of the Dr. Tina Show, I have a treat for you. I'm going solo on this episode, and I have been asked countless times by so many people on the internet, what are my thoughts on bioidentical hormone replacement? And while I feel like I've covered this at length, and I've done a whole series of podcasts on the topic, and I've talked about it intermixed into many of my other podcast episodes, I wanted to just come on today and share with you why I've been taking it since I've been in my 30s and share with you some of the things that I share with my patients and give you some information that I hope is very helpful so that you can make an informed decision for yourself, because there seems to be a lot of confusion out there and everybody seems to be doing things a little bit differently. There's the menopause group who I love. I love that there is a huge movement right now to help get the word out about the safety and efficacy of bioidentical hormone replacement, or just hormone replacement in general, hormone replacement therapy, HRT, as we're going to call it. If I say BHRT, that means bioidentical hormone replacement therapy. But there's also a whole group of people out there who I know many of you trust that are in the functional movement community, who don't have licenses to prescribe hormones, who don't use hormones in their clinics, and who also have the title doctor in front of their name. And for whatever reason, their license doesn't allow them to prescribe hormones. And many of these people oddly happen to be male chiropractors telling you that hormone replacement therapy is dangerous and that it does all kinds of terrible things. And then they turn around and try to sell you some supplements. And I talked about this a little bit on last week's episode when I covered the benefits of the microbiome, the gut microbiome, in the presence of GLP-1 agonists, and said the same thing then. So I won't go on a big rant here because I kind of already went on a rant over there. But I'm so sick of this. You guys, I'm so fed up. I'm so tired of listening to male chiropractors and male functional medicine experts who cannot prescribe hormones, who do not use hormones in their clinical practice, who are clearly not up on the data, talking about how dangerous hormones are. But you know what the funny part is? If it's a hormone that's available over the counter like progesterone, you betcha they tell you that one's safe. As long as they can sell it to you, they'll tell you it's safe. So it's just been a really interesting journey for me in my clinical practice. I've been at this since 2008. That's how long I've been licensed. And I've been able to prescribe hormones since 2008. For those of you who are new to me, I am a chiropractor. Yes, I am also a chiropractor, but I am a naturopathic physician in the state of Oregon, a licensed naturopathic physician, not a fake ND like many are online these days, but a real doctor in the state of Oregon. We are acknowledged as primary care physicians. We went through full medical training. We went through board exams. We sit for state exams. We are licensed in our state where we are. Not every naturopathic doctor is licensed. Every real one, I should say. There are several who graduated from the same program I went through who are not licensed because they are in unlicensed states. Not every state allows licensure. So it's very confusing for all of you. I won't go too far into that. But I have been able to prescribe hormones since 2008. And prior to that, I spent 2 decades in clinical practice assisting my mentor, Dr. Rick Marinelli, who prescribed a whole lot of hormones. So I know my way around hormones. I would not say I'm a hormone guru by any means. My background was that I specialized in chronic musculoskeletal conditions, regenerative injection therapies. And so a lot of my application of hormones was in the patient presenting with pain. And there's a whole lot of interlink between pain and hormones. And what I saw anecdotally in clinical practice and what I saw happen before my eyes countless times and what I've experienced personally around that subject, musculoskeletal pain, bioidentical hormone replacement, a whole lot of studies have come out recently. So we were using it knowing the mechanism of action, but not having the clinical data to back it up. And we would get pain resolution. We were obviously going on lab test results. And, a patient would come in, have symptomology of low hormones, and then present with labs with low hormones. We'd apply hormones, and then we would utilize bioidentical where we could. We would do what we needed to do by the patient, right? That's what we do. Meaning we meet them where they're at. If they can only afford to use their insurance and go with a more standardized hormone over, at the regular pharmacy, then that's what we do. And newsflash, estradiol is estradiol, whether it comes out of your compounding pharmacy and it's in an expensive cream, or whether it comes from the patch or in a pill form, or whatever form it comes in from your standard pharmacy, estradiol is bioidentical. It's estradiol. Now, where we get into trouble with things is the progestins. That's a topic for another day. I cover this in depth in my Ozempic Done Right University course, my big paid program. I have a whole module in there on hormones, and I could talk about it there. But progestins essentially are artificial progesterone. And where a lot of the issues with the Women's Health Initiative, over 20 years ago that came out, that was right when I started practicing, was right around that time. Or at least I was in school when it came out, and like when I was getting introduced to hormones and learning about hormone replacement therapy, that study came out, and I was taught very quickly by the folks who taught me how to safely and effectively apply hormone replacement therapy to patients that progestins, and I'm going to share this with you, and all the studies coming out since then and the reevaluation of the Women's Health Initiative data has shown that it's really the progestins that are the problem. So we were right. We never stopped prescribing. I've been prescribing hormones my entire clinical career safely and effectively, and patients were having really phenomenal results. And this progestin problem, it sits on the receptor. It mimics progesterone, but not completely. And it doesn't do what natural progesterone does or what a bioidentical progesterone does. And newsflash, you can get micronized bioidentical progesterone from your conventional pharmacy too. It doesn't have to be compounded. So however a patient gets a hold of the hormones, as long as it's bioidentical, we're happy, because that means it's going to sit on the receptor and do what it's supposed to do. And I was taught to never use estrogen alone, to use it in conjunction with a bioidentical progesterone. And that's what I've done. And so far, so good. Everybody's been great. But the data coming out in the last several years, especially, is really showing that estrogen, even estrogen-only therapy, has been shown to have some pretty incredible results with not nearly the amount of risk that we've been led to believe. And the reason I wanted to make this episode is because there is a whole generation of women who completely got screwed over by this Women's Health Initiative study. Hormone replacement therapy was around, from what I understand, around 40% or so of women who qualified for it, meaning women who were, I'm guessing, more often menopausal, although I will say, and I will die on this hill, start sooner than you think you need it. Get your hormones tested sooner than you think you need to. I needed hormones in my 30s. And the way I've done it is very much physiologic dosing. And I have kept my symptoms at bay. And now I'm sitting at 50, nearly menopausal, and really needing more standardized dosing. Anyway, women were using it back then. And then the study came out and it came to a screeching halt. And now roughly about 5% of women who qualify for hormone replacement therapy are actually utilizing hormone replacement therapy. And every single day that I mention hormone replacement therapy in any capacity, somebody comes at me, or a whole slew of people come at me and say, what about cancer? What about blood clots? What about all these things? And while I cannot give you the whole download in a podcast episode, because I want to keep this tight and potent, I will tell you that the delivery method matters. So when I'm referring to HRT, I'm referring to a topical estrogen. More often, as women get older, I rely less on a topical progesterone and more on a micronized oral. And then I definitely love utilizing testosterone too, and there's a myriad of ways to do that. So I talk more about all of that inside my paid program, but for the sake of this podcast, I just want to give you guys the quick and dirty on why I think utilizing hormone replacement therapy before you actually think you need it might be in your best interest, because changes that are happening, it's very easy to get behind the boat, if you will, and it's very hard to get caught up. And so what I mean by that is your hormones will begin to drop, you unbeknownst to you, and you start having symptomology that you're not really putting two and two together. This happens all the time with patients where they're not realizing that the symptoms that they're experiencing are a direct result of plummeting hormones for whatever reason. And disclosure, I'm not your doctor. This is for educational purposes only. As with everything on this podcast, I'm certainly not trying to encourage anybody to get on hormones. What I'm saying is go get tested sooner than you think you need to, and then consider physiologic dosing with somebody who's skilled. This is easier said than done because even in the pro HRT group of people, I often still see people getting dosed on really high doses. And I've experienced this in some of my trainings that I've gone to where they really crank people out on hormones. And my strategy is much more of a physiologic dosing strategy, much like I do with GLP-1s. I meet the patient where they're at and I dose them up to symptom relief and no higher. And that may not fit into an algorithm or into a standard dosing protocol, but I meet the patient where they're at and get them the symptom relief they need. It was really easy in my practice because my practice was all based around mostly patients having some level of pain, right? And so that would be the key symptom. And if we got pain down and we got them back to a more comfortable place, then we were on the right path. And then obviously utilizing labs to make sure that we are in a safe zone and different types of labs I like to use. Again, I talk more about that inside my paid program, but for the sake of today, I want to share a little bit about myself and my own personal journey. And then I want to share with you some of the reasons that are, really fair reasons why women may decline utilizing hormone replacement therapy, because I realize it's not for everyone and I want to honor that. Although there's a whole lot of women who think that menopause is a natural process and we shouldn't utilize hormones, and they're staunchly in that place. And to that, I don't get it. I just totally don't get it. Why on earth would you choose to have the vitality of your tissues in your body just be stripped away by the loss of hormones? Like estrogen makes us juicy, progesterone makes us calm. There's so many good things about hormone replacement therapy. Testosterone keeps us strong and virile. I'm going to go into some of my favorite reasons why I choose to utilize hormone replacement therapy, but I want to honor that some people can't use it, some people don't want to use it, and we'll talk about that too. And I'm not going to get too far into the cancer concerns. I will punch you over to a book called Estrogen Matters, and I'll tell you a little bit more about that author because I think that he covers it really beautifully, and I don't need to go into it here. I'm not here to convince you. I'm not here to try to talk you into it. I'm not here to try to talk you out of maybe some of the intentional ignorance that with all due respect, I run into this every single day with people online. I ran into this with my patients all the time when I was doing a lot of hormone replacement therapy in clinic. There's just a lot of intentional ignorance out of there. And I understand, the media scares us. It's hard to get answers, but even just a quick Google search at this point will pull up that really, I think the cancer concern can be, for the most part, put to rest in a large swath of women. And we'll talk a little bit about that. So anyway, let me share with you quickly my journey. So when I talk about hormones, I'm talking adrenal, thyroid, progesterone, estrogen, testosterone. And I started, as many young women need, being with very low progesterone. I see this clinically. In fact, I've never seen a normal progesterone level in a woman. And young woman, old woman, I haven't seen it clinically. And I've tested everybody's hormones. Progesterone gets wiped out, I think, in our modern stressful society. I think we are exposed to a lot of toxins. We're exposed to a whole lot of things as young women that maybe our generations prior were not having to deal with. And so low progesterone is really not a great place to be. And a topical progesterone can be quite lovely and helpful to many of my patients. Again, I'm not your doctor. I'm not suggesting anything. I'm not telling you what to do. I just want you to know what your options are. Progesterone is available over the counter in most states. So it's really quite a safe hormone. But I will say that too much is too much. And interestingly, too low and too little and too much of a hormone can really start to look a lot the same. There's a Goldilocks spot. And you can really overdo it if you start messing around with this yourself, even if it is available over the counter. So finding somebody who's educated who can help guide you is critically important, in my opinion. And I say this as someone who has taken too much. On my own accord, I have overdone it myself, and that's not a fun place to be. So from there, I have to say I've been a lot more careful with estrogen than maybe I should have been, to be honest with you. I have always dosed people really slow and low. And the problem with estrogen, as I've seen it clinically, and that many of my colleagues have seen it clinically, who actually are aware of metabolic health and who are aware of how to treat metabolic health and metabolic conditions, is that in the lean, fit, good muscle amount, good body compositioned female who's not terribly inflamed, who's not drinking a lot, who's generally following pretty healthy lifestyle protocols, estrogen is, I think, miraculous. When we get into your average American woman who is dealing with some extra adiposity, usually some inflammation, especially as she's moving through perimenopause into menopause, she's often looking at, metabolic compromise that's becoming more severe, especially around my age, like pretty severe at this point. And I think estrogen behaves differently in that body, and it gets real messy. And I have a whole lesson about this inside my program that you can go listen to if you join, because it just gets really, really messy. So estrogen, in my opinion, is not the same in every body. Not every body handles estrogen the same. And it's much more predictable in a lean, fit, healthy, good muscle massed woman who's getting adequate protein and sleeping and not drinking a ton and not smoking and all of that. In a typical American woman's body, estrogen can get much more unpredictable and start going down different pathways, which I don't love. So it's not as simple as give everybody estrogen. I just want to make that really clear. And then there's testosterone, which I think is just an amazing hormone. I've done entire podcasts about it. I've done two podcasts for men about testosterone, and I've done an entire podcast called Women Need Testosterone Too. So you can go listen to that. I even had slides on my YouTube version, so you can go listen to that. But I just think it's a really phenomenal hormone as well, and it's gotten a totally bad rap. So I encourage you to just get educated. I'm, again, not telling you to take these hormones by any means. I'm not giving you medical advice. This is just for educational purposes only, but there's women suffering, and my practice revolved around pain. And there were women in horrific pain who so desperately needed hormones, and they would fight me tooth and nail on it, or they didn't want to do it, or they didn't think they needed it because they thought they were too young or what have you. But if the body's responding by, having cartilage degradation and bone degradation and muscle loss and all kinds of other symptomology that can present as some version of pain in the body, and it's becoming more and more chronic, and we test them and they're low across the board, or they're low in certain things that we know can be helpful for that are hormones, they just would fight me. And it was wild because my job was to regenerate their tissues utilizing different substances, natural substances. But some of these substances could be quite costly. And in fact, all of these procedures are not covered by insurance. So they were all out of pocket. And I was like, why wouldn't you want to be in a good healing state, like a good anti-inflammatory healing state? Because at the end of the day, estrogen's anti-inflammatory. And we know that women who are menstruating are much healthier in general than women who are no longer menstruating or who have had their ovaries removed. And so we have so much data. Again, I can't get into all of it, but it doesn't make any sense to me why somebody would fight that. But here are some reasons that I've heard, and I wanted to share them with you. First of all, it's essential to evaluate your individual risks and needs, and you can only do that with a hormonally savvy doctor who knows what they're doing. And so there are certain concerns that are out there in the literature, like blood clots and cancer, but those are based on the type of estrogen that people are taking. So more often oral would be a problem. Again, what is the overall milieu of the individual we're wanting to put hormones into. That really does matter. If you're metabolically compromised and really inflamed, then that may not be the best milieu. And this is where I think GLP-1 agonists are so miraculous, because there's women who desperately need hormone replacement therapy because of their symptomology, because of their pain levels, because of a lot of different reasons. And they're so inflamed and dealing with excess adiposity and metabolic compromise that they can't really use them as safely as I would like it to be. And so GLP-1s can be such a beautiful opportunity here to clean up the terrain and clean up the milieu and really reset the metabolism and get some of that excess adiposity off and get some of that inflammation down. That's how they work in the body. I've talked about this at length on several different episodes. You can go back and listen to. I have a whole Ozempic Done Right podcast series that is getting pretty lengthy now. And you can go back and go to drtyna.com, drtyna.com, and go to the podcast page, and it's all right there. And there's a whole series right there laid out for you. Just start at the beginning at episode 106 and go on through, because I try to bring you guys some of the most updated information. Some of the information that I really want to talk about these peptides, I don't feel comfortable talking about on a public forum anymore, just with all the censorship I've endured. So, it's behind the paywall. It's in the paid program, and that's where it's going to be laid down. And that's where all the studies, that's where I share all the studies. I have I want to say the document's up to almost 30 pages now of all of my data that I found. And I share it all with the students inside there. I do a Q&A monthly where I field questions and try to answer questions there. And then I'm going to start doing a more consistent, case study breakdown, if you will, of different studies that I'm finding and where we are in the data, because the literature coming out right now around the two big C's that we shall not name is just phenomenal when it comes to GLP-1s. It's really exciting stuff. And so I'm sharing that in there. I wish I could share it all with you guys here, but we don't live in that world anymore. So, all right. So here are several reasons why a woman may choose not to initiate HRT. And again, each his own. I personally don't get it. I would never try to raw dog this on my own, but I understand that everybody has their reasons, and it is not my job to judge. I honor where people are, but these are the main reasons I hear. I will say this: delayed or late initiation of estrogen can have all kinds of devastating impacts on your body, and we have the data to support this. So, devastating impacts that could possibly have been prevented had HRT been initiated prior to the symptom severity or prior to a long time out. The data is showing about 10 years post-menopausally, it's still very safe to apply estrogen. But clinically, what I have seen is that sometimes it's too late to right the ship. And this is where my personal experience comes into play. First, I want to share the reasons why women may choose not to, and I'll get back to that. But I do think that early intervention with HRT is critical. And I think, again, getting evaluated, considering it sooner than you think you might need it is really important. I'm not talking, there's a lot of discussion out there about really early onset menopause. I'm not talking about that. I'm menstruating quite normally, to be totally transparent with you. It is getting a little bit, funny here and there, where I might skip one or might have an extra round of something because I am getting towards that tail end of perimenopause. But the idea is that you just sort of sail on in to menopause. It doesn't have to suck. It really doesn't have to suck. And not everybody needs hormones to have menopause not suck. I know plenty of very healthy, fit women, and they are all very fit. I will give you that. That's the caveat. They're all incredibly fit, and they have been training their entire lives. These aren't women who just figured out they need to start strength training like so many do. These are women who are incredibly high level athletes, and they just cruise on into menopause. It's no big deal. And so it's not so much about labs as it is symptomology for me. If a woman says, do I need estrogen? I'm like, well, if you don't think you need it, then let me ask you a few questions, right? And that to me is more telling if they have symptoms. And if you don't think you need it and you don't have symptoms, then you may not need it, right? So I was having symptoms and denying that they were symptoms. You see the difference there. So first of all, fear of cancer risks. This is a very common fear, and I think that a lot of it was is unfounded due to the Women's Health Initiative and how they scared the bejesus out of everybody when that came out in 2002. But there are certain types of cancers and there are certain types of women where this might be a real risk. And so obviously that's up to your risk tolerance and you want to talk to your physician always, right? But there's a fear that is quite unfounded and it is illogical. And many studies have come out since 2002, Women's Health Initiative initially dropped and really reevaluated the data in there. And that was a quite overblown situation. And I think it did a terrible disservice to, again, an entire generation of women. Estrogen used alone can definitely increase the uterine lining thickness, and that can put you more at risk. But the breast cancer risk really is not nearly there to the degree that we've been told, if at all, to be honest. And in many cases, it may lower the risk of breast cancer. So I won't get into that too far, but talk to your doctor, of course, and make sure your doctor knows what they're doing instead of just being like, oh, I'm against this. Many doctors just aren't educated and they're against it. Now, also, again, going back to the progestins, the fake progesterone, that has been shown to, as an HRT combo with estrogen, to be a concern of increasing all kinds of problems, including cancers. There's misinformation and lack of knowledge. This is on both the public and the doctor's part and the medical establishment. I don't know what it is, but I don't feel like the medical establishment really wants us having estrogen, and for various reasons. And I say this because it has come under fire. Different forms of estrogen have come under fire in the compounding world quite frequently since I've held a medical license. And I've always raised an eyebrow like, what? Why are they going after that? Like, why would that be concerning? So it makes you kind of go, when they keep coming back to try to take it off of the list of things we can make available to our patients, right? That always makes me raise an eyebrow. Some people prefer a natural or alternative health preference. Like that's the way they want to go. They want to raw dog it. They think that menopause is a naturally occurring process in a woman's life and that we should embrace it. And my bones and skin and cardiovascular disease and joints say otherwise. But if that's how people want to go, then that's how they want to go. And they want to use herbs and other things that are natural, and that's cool. But when your ovaries go offline, you can no longer stimulate them with an herb or stoke them with an herb to do anything. And so you really... It's just like the people thinking that there's like nature's Ozempic. There's just not. You can't replace a hormone with something natural. They're not comparable. And any doctor out there, chiropractor, telling you that his magic formula is the one that's going to give you the same benefits as estrogen that's just Looney Tunes. They're completely lying to you. There's a perception that menopause is a natural life stage, like I said, and that we should go through it so that we can experience it. And again, my joints and heart and skin and, libido just say otherwise. There is side effects and discomfort, or they're not tolerating it well. I used to be in this camp. I have always been a very low hormone girl. And when I tried taking estrogen back when I actually was getting symptomology in my early 40s, I really needed a little estrogen for various reasons. And I didn't use it because I wasn't tolerating it well. And that's just how it was. And I think it was, I wasn't going through enough opportunities of different forms to really find the place that landed me where I was tolerating it well and I felt better. So that can be a thing. You also can be getting overdosed, just like with the GLP-1s. A lot of doctors do standardized dosing, even in the functional medicine community. I've seen this time and time again where they do a standardized dosing protocol that they learned at a conference or they learned from someone, and it's just too high. It's just too high for the patient, and it makes them feel really, really crummy. And it, again, depends on the delivery. If you're giving somebody, X milligrams of a sublingual, that's going to be a whole different absorption than if you gave it to them in a pill form, right? So there's just a lot of variances that need to be taken into consideration. And so finding a doctor who's trained in this really does matter. There is a reluctance or lack of support from healthcare providers. That's huge. I've I've already said that. There's just doctors, they don't know. Endocrinology is complex and people don't want to take the time to understand it. Certainly don't go to your GP and expect them to have a clue, right? Like, why would they? We have to, as a society, we really need to just, if I can go on a rant for a second, we need to stop expecting every doctor to know how to do everything. Like, I don't do proctology exams. I don't do gyne exams. I don't want to. Can I? Yes. Was I trained to? Yes. Do I want to? No. I don't do peds. I don't take care of kids. I don't even remember half the things that I took board exams when it came to kids because I didn't want to treat kids. So I always joke, kids and cats, not my jam. Like dogs and adult humans, I'm good. But kids and cats, geriatrics, that's a whole other group. Geriatric patients actually have a lot in common with pediatric patients when it comes to their sensitivity of things. So, pick a doctor based on what they're really good at, because we're not all great at everything. I'm really good at musculoskeletal conditions. I happen to be good at a lot of things, but that doesn't mean that I'm great at all of it, nor that I had any interest in all of it. So let's quit getting mad at our GPs for not being a jack of all trades, because that's not what they were trained to do. There's cost and access issues, but again, I really want to drive this home. Micronized bioidentical progesterone is available through your standard pharmacy, and hopefully your insurance will cover it. And so are different forms of estradiol. It's bioidentical estrogen, and it's available at your standard pharmacy in patches, topicals, injections. There's all different forms. So access sometimes is just a matter of the patient needing to be more savvy. Again, doctors don't know everything, and they can't. They have lives too, and a bazillion patients to take care of if they're in the insurance model. So take it upon yourself to learn as much as you can. I do a pretty great overview inside my Ozempic Done Right University. It is not a hormone only course, and there's a lot more to be learned, but it is my attempt to educate you, whether you're a clinician or the general public, as best I can, and then talk to you about how these hormones work in conjunction with other peptides, GLP-1s, metabolically optimized insulin-sensitive lifestyle, like all the things. HRT is a huge part of that. So educating yourself is going to be numero uno for you to be successful in this. And that's why I created the course. And that's why I'm letting the general public in right now. We are working on making this a certification course for practitioners, and we will be kicking the general public out and definitely raising the price. So if you're interested in the program and you've been on the fence, buy it now, join us now before the end of the year, because things are going to change vastly in 2025. And I really want you to be as educated and empowered as possible. It's a beefy course. It's not for everyone. You have to be smart and you have to be interested in learning. It's truly a mini university in there. It's not just a kind of a casual overview. I really want you to understand what it is that you are utilizing so that you can be empowered and educated, so that you can have educated conversations with your practitioner. And if your practitioner is not the one, you can go find someone. There's a whole module in there on how to find a doc to help you as well. And there's a whole list of my favorite compounding pharmacies. And I just am trying to get you all the information that I can so that you can be educated and empowered. And I think for the right person, this is the most beautiful course. And, for some people, it's not the right course, and that's fine. And then there's social stigma and taboo around aging and menopause, which I'm not even going to go into that. I just think it is just crazy that a woman, it's always other women. It truly is always other women who come down the hardest on other women. And whenever I talk about hormones on my social media, it's always other women with this sort of condescending, matriarchal. Half the time, they're not even older than me, but they think they are. And they are so condescending, telling me what I should and shouldn't do. And the minute someone tells me what I should do, I block them, by the way. Just a little FYI pearl there. It's just nonsense. Like, I don't want to get old, and I'm not trying to stay 25. I'm just trying to be the hottest, happiest, fittest, juiciest 50-year-old version of Tina that I can be. And I will hang my hat on that, right? And when people say, oh my God, you look amazing, or your skin looks amazing. Like, I don't think I do, to be honest with you. I can see the aging happening, but man, it's hormones. Like, I've been using them for a long time in tiny little increments as needed. Throughout my life, I have been utilizing hormones since my 30s, and you will pry them out of my cold dead hands. So when women look fantastic, I guarantee you 99% of the time, there's some hormones going on there. So this whole social stigma thing and this taboo, it's coming from other women. And again, it's coming from influencers and health professionals online that are going to convince you that their workout program or their supplement or their whatever is going to do it. And it's like, no, dude, it's not going to do it. I'm sorry. So if they can't prescribe hormones legally in their license, then I honestly don't listen to them when they talk about hormones, because they don't understand the magic salve that can happen for a patient when the right hormonal treatment plan is implemented. It's really phenomenal. I have seen chronic pain reverse. I have seen depression, and I'm going to get into it here because there's data to support everything I'm saying. This is not just opinion. My own personal experience was a few years ago at the height of the stress of pushing back on the narrative. My poor little ovaries were like, and my poor adrenals couldn't keep up, because your adrenals actually, I go into that in my course too. Your adrenals are what are playing catch up for your ovaries when it comes to estrogen production. And my poor adrenals were just fried. They're like little piles of dust upon my kidneys. And I don't know if you guys saw that study that came out recently. It's not the first time this has been shown, but we age in precipitous drops. It's not like this slow, gradual aging that happens. Age 44 and age 60, there's like two big dump outs, and we age pretty severely during those times. Mine, I think, was a few years later than that. So I was rocking and rolling at 44. I was feeling fantastic at 46. And then like right around 48, it got hard. Things got hard for a minute. And I went into, chronic pain spiral. My autoimmune disease came roaring. And I've shared all of that when I've talked about my journey with GLP-1 agonists. But my estrogen delivery system wasn't cutting it. I was using a topical, and I've had this happen with patients where, it's just not cutting it. Like, we have to play around with different delivery systems for different patients. And so I finally slapped an estrogen patch on, and thank God. I will just leave it at that. Thank God for the estrogen patch, because that pain level coupled with and I didn't even know it. Like, the GLP-1 agonists were really helping, but I didn't even realize the amount of pain I was living in, because I was feeling better. I mean, I must have been in a terrible place, because the GLP-1 agonists really changed the game for me. And I did have estrogen on board, but it was a topical, it was a liposomal delivery system, and it just wasn't cutting it. Probably me. It wasn't the product. I was not consistent. I just wasn't being consistent. And there are problems with fluctuations in estrogen. That often can cause a lot of symptomology of pain and different symptoms that women get, because it just bottoms out and then they bring it back up. There's something about that steady state patch that did it for me. And it's been just completely a game changer for me to actually have steady state estrogen in me at the right dose. And I really had to titrate up my levels and find my own individualized dose, just like I teach you guys and I talk about at length inside of Ozempic Done Right University. And I feel a million times better. I'm also using micronized oral progesterone. I use a topical testosterone, and I feel fantastic. And I use Estradiol, which is a different form of estrogen. I use that topically on my face. And I was just at an event, and everyone's like, God, your skin looks the same in person as it does on the internet. And I'm like, oh, thank you. I think my skin looks atrocious half the time. But I was so happy to hear that, because it's the Estradiol, right? It's miraculous. And so you can get all of these things from your doctor, your hormone savvy doctor. Let's get into my top 6 reasons of why, based on science, of why I think that women should consider starting estrogen earlier than they think they need it, and what low estrogen puts us at risk for during menopause. And again, I'm not telling you to take estrogen. I'm telling you to consider getting tested and consider taking it if you've been on the fence about it and you feel like you need it, because it's shocking. For me, I really thought it was everything else, because I was using, actually, like I said, a liposomal estrogen, and I thought it was everything else. I was just chasing my tail in circles. And when I finally got the steady state estrogen on with a patch, I was like, that was it. That was like the missing link, right? And so you got to be patient. You got to play around with this, and you have to just look at the writing on the wall, right? I wasn't having vasomotor symptoms. I wasn't having low libido. I wasn't having, some of the more classic symptomology. I was having really severe brain fog and depression. And I have had severe depression on and off throughout my life. And now that I think about it, it was always when I was messing around with my estrogen, either back as a teenager or a young college student with oral contraceptive pills, or I was in a period of time when I was very, very, very lean, because we pack our hormones into our fat, and I always say our little pooch is our little estrogen depot. And the times when I got 6-pack abs and I got really, really lean, and my estrogen probably was going down or very low, and I've in fact tested during those times and it was very low, I had also been met with this very severe, unshakable depression. And it's you don't even know it's there until it's gone, to be totally honest with you. Because when it lifted more recently, when I got on the patch, I was like, oh, I didn't even know I was carrying that load around with me. I was just sort of battling through it like, oh, this is just my normal, this is, I'm kind of a Anakin Skywalker, grumpy Gus, if you will. I mean, I'm very pleasant and happy, and I have a big, huge heart, but I can also just sort of live in the I like to wear black, and I like to listen to heavy metal, and I can just kind of live in that darker place, and suddenly I'm like, oh, I feel very pleasant. I didn't realize I was just terribly low in estrogen. So anyway, I'm being very transparent with you because I'm sure some of you can relate, but it's no joke. I just heard a stat. I think it was Dr. Mary Claire Haber who shared that. I mean, this is really upsetting. Women in the UK, I think the stat was age 45 to 49, have their highest rates of unaliving themselves than any other age group for women. And I'm going to share some stats with you that are just really just kind of earth-shattering around that. And I had a friend when I was in high school, and his mom was really severely depressed, and he was the nicest kid. We were all just like rocker kids who used to sit in the basement and listen to Iron Maiden, and really smart group of young men, actually. Anyway, this kid was so nice, and his mom was always chronically depressed, and we just really tried to support him because we knew that must have been really hard to live with. And right after graduation from high school, she unalived herself, and I was so heartbroken. It was like she waited for him to get to that age. And as somebody who has struggled with that feeling before myself, on and off throughout my life, I have always been terrified that it was going to come back and get me. And I always say, when I see different rock stars or celebrities, you hear about that happening to them. And I always say the darkness finally got them. And because it chases you, and any of you who've been there understand what I'm saying. And I was feeling it come back for myself. And the world's in chaos, like just utter chaos for however many years on end now. It's been really bad, since 2020. And as you guys know, I've endured a tremendous amount of stress and pushback and censorship. And I just thought it was all of that. And then I get my estrogen on a steady state, and I'm like, oh, the darkness is lifting. I just needed some estrogen. The work of Dr. Lisa Mosconi, who I'd love to get on the podcast, if any of you want to put in a plug for me, we're working on it. She wrote a great book about the menopausal brain, and she talks about how as soon as estrogen levels start dropping, the brain starts upregulating estrogen receptors in the brain, like it's searching for the estrogen. It's terribly trying to bind to anything it can get its hands on. And so that just shows that we need estrogen in the brain, and the lack of estrogen in the brain is devastating. And her book is phenomenal. And really, she makes a great case that that menopause starts in the brain, and it's really, really, really devastating what happens to some people's brains, and probably most women when their estrogen gets too low. Some of us just handle it differently than others, depending on how our brain chemistry is. But low estrogen in the brain was a miserable place for me to be. And I didn't realize that's what was happening. I just thought it was me. And the darkness was coming back. And that's just what happens when you age. And it was just something I was going to have to contend with. But when I put that first patch on, I woke up the next day and I felt like I had been tranquilized. I was so pleasant. I was just floating. And of course, I went on to Reddit because I wanted to see other people's experiences. And they were like, I don't like it. I feel almost detached from reality. I'm like, I think this is great. It is such a pleasantry. And I will say after, many, many weeks, that has worn off a bit. but I feel so much more pleasant and calm. And that whole deplatforming episode on Instagram, I don't think I would have handled it nearly as calmly as I did without the estrogen patch. But it's just really phenomenal. And then progesterone, when you get your levels to the right place, it's so phenomenal for sleep. It's an anxiolytic in the brain. It really is a neurohormone and a neuropeptide. And these are really act as neurotransmitters in the brain, estrogen and progesterone both. And I dare say testosterone. It's just not having them versus having them is an entirely different game. So, okay, let's just straight up, estrogen's anti-inflammatory. The impacts on the brain are phenomenal. And here are the main reasons that I choose to use it. Number one, heart health. We know this. We've heard about it. Estrogen keeps us juicy and elastic. That means our blood vessels as well. And it promotes healthy lipid metabolism and healthy lipid levels. It reduces inflammation. And women who are postmenopausal face dramatically higher risk of heart disease. And that's due to the loss of the cardioprotective estrogen. So that's a big deal. Cardiovascular disease becomes the leading cause of death in women after menopause. As I said, women who are menstruating are much healthier. Women who have estrogen on board are much healthier. Our tissue health. This means your bones, your joints, your muscles, your skin, all of your tissue, your gums. It's very protective in maintaining bone density, which you've heard about, and for regulating the osteoclast and osteoblast, which is your bone resorption and bone promotion. But early HRT, not late, early HRT can significantly reduce the risk of osteoporosis and fractures. Women with low estrogen levels during and after menopause experience accelerated bone loss. And I will say, I've seen it clinically, accelerated tissue loss. Frozen shoulder. That's a menopausal issue. When have you ever seen frozen shoulder? I mean, I've seen it once in a woman who was younger, but she had gotten very, very thin. And so I think she did lose her hormones. And it can be tied to, obviously, blood sugar. That's a big one, we know, and tied to thyroid health. But estrogen and progesterone play a role here as well. Joint deterioration, I have seen time and time again, and including myself, all of a sudden the joints just seem to start melting, and it's bilateral, and it's concerning, whether it be knees or hips or shoulders. A woman comes in and things are going to hell fast in a handbasket, and usually I'm watching as we track them, their hormones just dropping. And some of them will quickly say, yes, give me the HRT prescription, and others will fight me on it. And I just watch their joints decline, their joint health, because again, it's anti-inflammatory. We have estrogen receptors inside the joint, on the bones. They're everywhere. It's not just, we think of estrogen and reproduction. It's not just that. Estrogen mitigates our cytokines. So pro-inflammatory cytokines like TNF alpha, interleukin 6, those are under the umbrella of what estrogen mitigates. And we do not want those running rampant in our body. It preserves cartilage. It helps with synovial fluid regulation. And also synovial fluid starts to get thick and goopy and gross when our hormones are off, including, again, our thyroid. So estrogen's very protective when it comes to joint health and reducing inflammation, bones, tissue, our mouth and teeth. This is a big one. A lot of women, I've heard this so many times, women say, oh, I went to Mexico 20 years ago and I had bad dental work and now my teeth are falling out. I'm like, I don't know, honey. I think your teeth are falling out because you have osteoporosis. And as the mandible starts to dissolve from the osteoporosis, the teeth start getting loose. And as the estrogen is declining and leading to that osteoporosis and driving it, you're also losing tissue integrity. And so we start to lose our face tissue integrity. If your face is all wrinkled up, you can bet that your bones are a mess. And trust me, if your face is wrinkled up, if you've got a lot of wrinkling of the skin going on, your bones are probably a mess. And your gums are tissue as well. And your genitourinary system will become compromised. That's my next point that I'm going to get to that I think is really important that women don't appreciate. So just know that all the tissues of your body, the integrity of them, the heft of them, the bounce of them, the ability to just be healthy and non-inflamed and non-friable and not sort of deteriorating on our skeletons and not having our skeletons deteriorate is very contingent on adequate estrogen levels. So if you want to keep your teeth and you want your gums to be healthy, in fact, since I got my steady state estrogen patch going, my gums stopped bleeding and they were really giving me a problem for a minute there. So tissue integrity, guys. Plus, who wants to look old and haggard? I don't. I mean, that's the argument that whenever women are like, just go through menopause, it's natural. You don't need hormones. Hormones are poison. I look at them. I go look at their profile and they all look haggard AF. I do not want to look haggard. Every single time I hear somebody who is my age or older talking about how awful hormones are, they look haggard AF. And I'm sorry, I'm vain, but I don't want to look haggard, because when you look haggard, your insides are haggard. It's all the same. I don't want haggard organs. I don't want haggard bones. I want resilient bones and resilient organs, right? Our eye health, it's protective to our eye health. So estrogen helps maintain eye health in the cornea and the tear ducts, reducing the risk of dry eye syndrome and other related issues. I've seen burning mouth syndrome with women who needed estrogen. It's a big deal. I'm going to come back to brain health here, but I'm going to jump down to the genitourinary system, because one of the big things that happens is we start to get atrophy of our tissues down there. And that leads to all kinds of problems, not just problems with intimacy, not just problems with pain during intimacy, not just problems with inability to climax and enjoy intimacy, but to actually start having UTIs. I've seen this with so many women where they start getting chronic urinary tract infections because the tissue's atrophying, and they use a little, we prescribe a topical Estradiol, which is the type of estrogen that I was talking about that I use on my face, and it gives them integrity back to their tissues down there so they can alleviate the misery of all of those things, actually enjoy intimacy again, and not be walking around with chronic UTIs. Because unfortunately, what I've seen in women as they get older, they will often experience UTIs without symptoms nearly as bad as, say, when I get one or when I was younger, that it can be so painful, right? You get a urinary tract infection and you're in so much pain. I've had them go into kidney infections. That's a very dangerous place to be. And I have seen many women who are elderly who've maybe lost their partners. And it's, the tissue of the genitourinary system is sort of a use it or lose it scenario as well. And so they're not using it. And then they start getting chronic UTIs, and it's really a terrible place for them because they can go into kidney infections and get very sick very fast and not even know it. Let's talk about brain health, cognitive function, dementia prevention, and depression prevention. So I already talked a little bit about what happens with the receptors, Dr. Lisa Mosconi's work. She's got the book is The Menopause Brain. Again, check it out. I'll put a link in the show notes for you. But a brilliant read, and I think absolutely mandatory. The New Menopause is Dr. Mary Claire's book, also great. And then Estrogen Matters by Dr. Blooming is phenomenal. And I think that all of those that'll give you the quick education on hormones that you seek. So anyway, estrogen has neuroprotective effects. It supports brain function and potentially reduces the risk of neurodegenerative diseases like Alzheimer's. Early initiation of HRT has been linked to better cognitive performances. And in fact, later initiation has been linked to worsening of dementia. So this is yet another reason why I say earlier is better. There is this theory that it's called the critical window hypothesis. And this study was done in 2007, and they basically concluded that the critical window hypothesis, which suggests that HRT is most beneficial for cognitive function if initiated during the perimenopausal, so like I said, before you think you need it, or early postmenopausal period, delaying HRT until later in life when the brain may have already undergone these age-related changes and neurodegeneration can lead to increased risk of cognitive decline and dementia. I will note, going back to the bones and tissue, same there. I have been reading a lot about estrogen and pain lately, and it seems to be that estrogen can make pain worse if it's too late. So what happens is some of these central nervous changes, some of these osseous changes, some of these degenerative joint changes happen, and then applying estrogen can actually make things worse. I think that some of the issues I ran into with my back, my spinal pain, I think I waited a little too long on the estrogen. And so there's a few spots in my back. I mean, my whole back was an issue, and there's just a few spots here and there left, and they're significantly calmed down. And I will say, when I go off the GLP-1 agonist for too long, that pain also comes back. So there's something happening there with both of them. But I think that sometimes we get too far behind. And that's why I say, again, I'm going to keep repeating it. Do this sooner than you think you need to. Please look into it at least. Get yourself set up, start researching, find yourself a good doctor who's educated and who's savvy around hormones. So let's talk some more about the brain. A rapid decline in estrogen in menopause has been associated with an increased risk of cognitive decline, like I said, and higher likelihood of developing Alzheimer's disease and memory issues. So that's a problem. And then the depression stats, perimenopausal and postmenopausal depression, studies suggest that up to 30 to 50% of women experience some form of depressive symptoms during the menopausal transition. That's half of women going through a process, if they live long enough, that they're going to go through. The risk of developing major depressive disorder increased by 2 to 4 times during this time. Women are 40% more likely to experience depression during perimenopause. So if you are perimenopausal and you feel like your brain is just going on you, for me, it was brain fog mixed with this. It was like a cocktail of brain fog, depression, and just not being able to remember what the heck I even did yesterday, and a lot of frustration around it. Look into having your estrogen levels tested by somebody who knows what's up. Now, when you're in perimenopause, your levels are going to be all over the place. So that's why it's important to find somebody to work with who is willing to work with you on this, and maybe go on a trial run of some of these hormones as needed and track you safely and responsibly. Because just saying, oh, well, so many people going, oh, you're perimenopausal, their doctor says, so there's no point in testing and there's no point in trying anything. Just wait until your periods are gone. I'm nowhere near my periods being gone at this point, and I don't think I could have waited any longer. Like, that would have been miserable. So find somebody that you can work with. You're probably going to pay out of pocket for them, and they're probably not going to be cheap, because anybody worth their salt isn't stuck in the insurance model, because the insurance model is, that's a topic for another day. So expect to pay out of pocket, invest in yourself, and find somebody who can help you. There was a 2015 study in JAMA Psychiatry, a longitudinal study published, found that incidence of depressive symptoms increased significantly during the menopausal transition. Again, women going through perimenopause were 2.5 times more likely to experience depressive symptoms than premenopausal women. So this is just study after study after study showing. There's a 2024 study in the Journal of Affective Disorders, The Risk of Depression in Menopausal Stages, a systematic review and meta-analysis. The perimenopausal stage, similar to prior research, the study found that perimenopause is the most vulnerable stage for depression, with a significant increase in the incidence of depressive symptoms. This heightened risk is linked to hormonal fluctuations, obviously, particularly the decline in estrogen. The postmenopausal stage, the risk of depression remains elevated in postmenopausal women, though it tends to decrease compared to the perimenopausal stage. So they seem to kind of get over the hump, and it sounds like the brain regulates out. So if you're one of those people who really want to raw dog this, then you may get to the other side and things will improve. I have seen that with countless women in my practice who didn't want to do hormones. They went through a really terrible phase, though. Their family members would say, and some of you probably had experienced this with your mothers or even yourself, like, my mom went crazy for like 5 years. That's what people will say. And I saw it with patients. Like, I watched them lose their wits for 5 years. And then all of a sudden they were calm again as they sort of moved through it. But this can go on for 5-10 years for some women. Like, why would anybody want to go through that? I don't want my brain to go through that. That doesn't sound like a fun thing to have happen. Hormonal stability in postmenopause offers some protection, but the long-term effects of estrogen depletion may still contribute to depression in some women. And if your brain is going through depression, it's probably shrinking, and you're probably dealing with an increased risk for dementia. So depression and dementia go hand in hand, and depression and pain go hand in hand. So I just think all of that is unnecessary if we could just slap on a patch. And truthfully, if your insurance covers it, it's pennies on the dollar to get your monthly supply of patches. Again, we want to have the micronized progesterone on board, or some kind of progesterone that works for the patient. Hormonal and psychosocial influences. The study emphasizes that both biological factors and psychosocial factors like life stressors, aging, health concerns. I've talked about this on the podcast. We are a stressed out group here in this middle-aged women group. Are key contributors to increased risk of depression. So anyway, all that to say, mood regulation, mental health, give me the estrogen and progesterone. I'm here for it. And estrogen also plays a crucial role in serotonin regulation. That's very important for our mental well-being. So anyway, enough with that. And then the big one, metabolic health and insulin sensitivity. As our estrogen wanes, our metabolic health declines because our insulin sensitivity also wanes. We will become more insulin insensitive. We will become more insulin resistant as we age, no matter what, as the estrogen wanes. I don't want that happening for me personally. That leads to weight gain. That leads to the middle-aged middle. I have done a whole podcast about it. You guys can go listen and check that out. Just a few weeks ago, I did that. No, thank you. Like, no, thank you, diabetes down the line. No, thank you, heart disease. So just forget everything I just said about losing estrogen and the direct impacts on the body. Now let's talk about all the horrific things that metabolic dysfunction does to the body. So you're getting it twofold. You're getting the increased risk of heart disease and bone loss and joint degradation and brain degradation from literally cause and effect from the lowering of the estrogen. And now you're getting it due to the insulin dysregulation that's happening in the body and the metabolic bustedness that you're heading into as your estrogen wanes. So it's like a double whammy. And I just say no, thank you. I don't want the weight gain. I don't want the fatigue. I don't want all of the downstream impacts of what busted metabolism does to a person and what insulin resistance does to a person. So, and then just a word on hot flashes and night sweats. I just want to share some information that you may not know because a lot of people don't know this. They think, oh, it's just hot flashes. It's no big deal. I'll just sweat it out in my bed. No, it's not just hot flashes. Here's what happens with, these are called vasomotor symptoms. Here's what happens. Vasomotor symptoms as predictors of overall health risk. Let me just read a few. Here's some recent findings. Severe vasomotor symptoms are increasingly being viewed as markers of systemic health risks. Women with frequent hot flashes have been found to have higher levels of inflammatory markers, which are linked to an increase of several chronic diseases, including cardiovascular disease, osteoporosis, and diabetes. There is cardiovascular risk, like I said. There is a direct link between vasomotor symptoms and cardiovascular disease because it's related to vascular dysfunction and endothelial health, which is the inside lining of your blood vessels. They get spasmy. And here's another thing. If you take estrogen early enough, it can help with your endothelium and be protective to your vasomotor reactions. On the other side, if you wait too long and you're inflamed and you're in metabolic dysfunction land and you're in that excess adiposity land, it can actually vasoconstrict and become more dangerous. So this is where that window of opportunity is so important to get the estrogen on board so you don't end up over there where estrogen is not your friend and it's potentially dangerous. I want to stay on this side of things. There's also data showing cognitive decline linked to vasomotor symptoms, memory issues, cognitive impairment later in life, sleep disturbances, Alzheimer's disease, bone health, osteoporosis risk, increased risk of, again, insomnia, which leads to increased risk of mental health issues. All of these are linked to poor vasomotor symptomology. So if you're having vasomotor symptoms, it's not just hot flashes. It is a harbinger of doom, in my opinion. And when a woman comes in and says, I'm having the worst hot flashes, I'm like, oh no, that's not good. I wasn't having any overt hot flashes at night. I just get warm. And I do get warmer than I used to. So I guess that's like a baby hot flash, but that's significantly improved with the estrogen being steady state. Also, not drinking. I sweat to death during the night if I have been drinking, and drinking makes all the vasomotor symptoms much worse. And I used to sort of sit there as women in their menopausal years would come into my clinic and say, oh, I can't drink red wine anymore. It gives me hot flashes in the middle of the night. And I'd be like, oh, you poor lady, that must be terrible. It is terrible. I am experiencing it now. I'm so sorry to anyone that I did not fully honor your symptomology. It's terrible. And so red wine is not my friend. It messes up my deep sleep. I look at it on my Oura Ring. I have an 8 Sleep mattress topper by a company called 8 Sleep. That thing actually cools me down automatically, which is so great. And when I sleep somewhere else that's not this mattress topper on my own bed, I do end up getting kind of sweaty in the night. So, but my husband's like a Bunsen burner, and if there's any kind of mattress pad in the hotel, he'll like heat it up with his body heat, and then it gets to me, and then I get super hot. There's also an increased risk for diabetes. There's been a connection found between frequent hot flashes and increased increased risk of developing type 2 diabetes. So vasomotor symptoms, i.e. hot flashes, they're not benign. All right. I'm going to leave you guys with that. There's so much more I want to talk to you about. I am working on it. I'm going to find a way. Maybe it's going to be a book. Maybe it's, who knows, but I'm going to find a way to keep talking about this because there's so much I'm digging up that I think is fascinating that I want to share with you all. If you guys found this episode valuable, I would really appreciate if you would subscribe wherever you're listening to it. I am usually on Apple Podcasts or on Spotify. You can also find these episodes, most of them that are not censorable, over on YouTube. And I love it when you guys rate, review, and subscribe. The ratings help me tremendously because it helps me rank in the algorithm and it helps other people see the podcast. So you guys have been phenomenal. My whole platform is real, it's organic, and it is truly people's just driven. Like, this is old school grassroots. You guys are driving this ship, and I appreciate you all so much for being here, and I appreciate you for spreading the message. And I hope that my content is binge worthy for you because I'm really trying to educate you, again, to empower you so that you can have educated conversations with your doctors. On that note, I have a free video called Finding a Good Doc, which is just like a quick and dirty version of the things that I look for in a good doctor because I cannot make personal referrals for you and I am no longer taking new patients. So you can find that on my website. It's drtyna.com/find a doc. You can also jump into my 4-part video series called Ozempic Uncovered if you want to learn more about GLP-1s and just things that you may not have heard about in any of my podcasts yet or anywhere else on the news media, because we're getting bamboozled on this. And I think it's just crazy. What's coming out is really stunning. And I'm keeping up with that information inside my paid program. So after you'll get a video every single day. It's at drtyna.com/Ozempic Uncovered. You get a video every single day for 4 days, and then you will be offered the big program and with a nice discount on top of it. And you guys can grab that there and join the course while it is still available to the general public. If you're a clinician, I highly suggest you jump in there now before the price goes up. I have been getting great feedback. I was just at an event that was all health practitioners, and people were coming up to me and they're like, this course is a dream. This is what we wanted. This was an amazing introduction into peptides. And I talk about lots of other peptides in there. I'm actually going to be updating because we just got word that some of the peptides are back and we can prescribe them again. So I'm going to be doing an update inside that course if you guys are in there. I'm going to be adding a lesson about the new peptides that are back. They're old, but they're back again. So very exciting, new to many of you because you maybe have not learned about them yet. So that'll all be inside Ozempic Done Right University. So get in there with me before the price goes up and before we reformat the whole thing. So I will make sure that the links to both of those free opportunities are in the show notes. Appreciate you all very much, and I will see you next week. Thanks for listening to The Dr. Tyna Show. This is a Wellness Loud production produced by Drake Peterson and mixed by Mike Fry. Theme song is by John the Guilt. You can watch the full video version of this podcast inside the Spotify app or on YouTube. As always, you can email the podcast at podcast@drtyna.com. That's DRTYNA. And if you like this episode, please rate, review, and subscribe on your favorite podcast app. You can also find all of my offerings on my website at drtyna.com. For more shows by my team, go to wellnessloud.com. See you next time, and thanks for listening. This podcast is for general informational purposes only. It does not constitute the practices of medicine, nursing, or other professional healthcare services, including the giving of medical advice. I am a doctor, but I am not your doctor. No doctor-patient relationship is formed. The use of this information and the materials linked to this podcast is at the user's own risk. The content on this podcast is intended not to be a substitute for professional medical advice, diagnosis, or treatment. Users should not disregard or delay in obtaining medical advice from any medical condition they have, and they should seek the assistance of their healthcare professionals for any such conditions.